Hello, everyone. We'll get started. My name is Mike. I'm one of the second year fellows at Stanford. And so thank you for joining our fellow webinar series in advancing career development in GI and hepatology clinical care. So objectives for today, upon completion of this webinar, participants should be better able to manage the uncomplicated pregnant woman with inflammatory bowel disease, understand the role of emerging agents in inflammatory bowel disease algorithm, and to be able to achieve these objectives, we are thankful to have Dr. Mahadevan join us to present today. A few other housekeeping items to let you know. Webinar instructions, you'll actually stay muted for the most part, but during clinical cases, if you have anything that you want to share, go ahead and press the unmute button. As part of this, so that we can all see each other, please enable your video so that we can make this as in person as possible as we can achieve during this pandemic. In order to ask questions, please send your messages through the chat box so other people can also view your questions, and I will verbally relay those to Dr. Mahadevan during the lecture. To change your username, and also for that, that we are able to keep track of who is at the meeting, you can go ahead and rename your name to something that we would be able to recognize. If you're interested in CME accreditation, there are a few things that you will need. You'll need an evaluation form and post-test after each webinar. You also will need to fill out a pre-test as well. The link to the survey will be sent to the email address that you used for conference registration. If you aren't sure about the email address you used to register, go ahead and send us an email at the email below. The pre-test link for those who are interested in obtaining CME is below. I'll give you guys a moment to click on that if needed. You may also have received that through an email. Okay. For fellows who are interested in being reimbursed for a webinar meal up to $30, there are a few things that you would need. One, you have to ensure that you are an NCSCG fellow, and you may register and renew your membership through the emails that have been sent to you. Turn on your webcam during the video and then send us a receipt. And you can send that with an accompanying expense reimbursement form to Danny Smith at dsmith@pacemed.com. Okay, and then we are grateful for the help of educational grants from Ferring Pharmaceuticals, Melancrop Pharmaceuticals, and Takeda Pharmaceuticals. Tonight, we're lucky again to have Dr. Uma Mahadevan from UCSF presenting complex IBD cases, IBD in pregnancy, and new therapeutics in IBD. In subsequent months, we will have a few other different presentations. In March, we'll have Dr. Haas presenting on reflections on 2020, aspiration for 2021 via a science of happiness lens. And Dr. Nguyen and Dr. Park will be presenting in April and May, so stay tuned. We're thankful for the different fellows and different chairs that have been presenting, have been helping out to organize these webinar series. Going forward in June 26, 27, we'll have our NCSCG, sorry, stumbling over this acronym multiple times today. The NCSCG GI Symposium that will be at Monterey Bay at Intercontinental Hotel. The details are still to be determined given the pandemic, but we're thinking it'd be some sort of hybrid in-person and virtual event. And so thank you again for joining us. And so if you're interested, follow us on Twitter, subscribe to our YouTube channel, and follow us on Facebook. So today we're lucky to have Dr. Mahadevan, who will be presenting today. And so a few things about Dr. Mahadevan. There's so much to say about her. Her resume is multiple pages long, so there's so much to digest here. So in a brief summary of her massive resume, I wanted to say that, so she went to medical school at the State University of New York in Brooklyn, followed by residency at Mount Sinai Medical Center, then pursued a fellowship in GI at UCSF, followed by an IBD fellowship at Mayo. She is a professor of medicine at UCSF, clinical services chief for gastroenterology, and co-director at the UCSF Center for Colitis and Crohn's disease, and the director of the IBD fellowship. She's a fellow of the AGA, for whom she was chair of for the clinical immunology, microbiology, and IBD section, and chair of the AGA National IBD Parenthood Initiative. She's a fellow of the ACG and served on the Educational Affairs Committee and is a member of the Advanced IBD Fellow Curriculum Committee. She's currently chair of the Crohn's Colitis Foundation Clinical Research Grants Committee, a member of their National Scientific Advisory Committee and Task Force on Women in IBD, and co-chaired the annual Crohn's Colitis Congress in 2020. And beyond that, she's also special section editor for the journal Gastroenterology and an editorial board member and reviewer for multiple journals. She has written multiple original articles, multiple editorials, and invited reviews. She specializes in the treatment of ulcerative colitis and Crohn's disease. She has a particular interest in pregnancy and fertility and IBD, as well as in clinical trials of experimental therapy for both ulcerative colitis and Crohn's disease. Her current projects include a national prospective registry of pregnancy outcomes and drug safety in women with IBD on immunosuppressive and biologic medications, clinical trials in biology therapy for IBD, and the impact of nutritional interventions in the management of IBD. And to top that off, she was also president for NCSCG back in 2005 and has been a member with us since 2002. Okay. Dr. Mahadevan, thank you so much for coming to talk to us.
Hi, Mike. Wow, thank you for that wonderful introduction. So good evening, everyone. It's great to see you. As Mike said, please leave your cameras on if you don't mind. I don't mind if you're eating, but it's nice to see a face. And I think Mike is going to be moderating the chat. So Mike, if there are any questions that come up at certain points, feel free to just jump in and ask the question. And then also at the end, there are a few clinical vignettes that I would love to get everybody's opinion on, and there are no wrong answers. This is all very private and we're all learning here. So to start, inflammatory bowel disease is a topic today. If you want to follow me on Twitter, it's Uma Mahadevan IBD. And my disclosures and the objectives. So the outline, we're going to go through pregnancy and IBD, optimizing current therapy, novel therapies, and then we're going to do a few case vignettes. So let's start with pregnancy. Mike mentioned the IBD Parenthood Project. This was a first joint statement between OB and GI. So it was the American Gastroenterology Association and the Society for Maternal Fetal Medicine. And it came up with this clinical care pathway. And for your patients, there is a really great website, the IBDparenthoodproject.org, where they can go and see very sophisticated and well done cartoons and toolkits and other things to help them absorb a lot of the things you told them in your office. And for providers, the gastro article link is below. So the clinical decision support tool that came out of this went through preconception, the 9-month pregnancy plan, delivery, and the postpartum. So what do we do in preconception? This is a very important time. Preconception doesn't necessarily mean the 3 months before they get pregnant. It can, when you look at a patient, it can be anywhere that you see them, because what you want is you want to plant the seed that when they're ready to get pregnant, they should come talk to you first. But in those 3 months prior to pregnancy, there are certain things that you need to make sure are done. First is disease management. They should be in a 3-month steroid-free remission prior to conception. That's very important because that time amount is what has been shown to reduce the incidence of flares during pregnancy. And you want to confirm remission. For most of my patients, I will do some sort of endoscopy unless they've had one very recently that confirmed remission. Fertility in this patient population can be reduced if they've had surgery in the pelvis, and IVF may not work as well in the patient with IBD. So we usually wait 6 months of really trying, and if they fail, we send them to a reproductive endocrinologist at that point. You may need to have nutrition involved to make sure they're getting adequate intake. Low birth weight in the mother with IBD is common and is associated with increased adverse outcomes in the infant. I have all my IBD patients, even if they're in remission, see a maternal fetal medicine specialist. They may deliver locally, but the MFM will see them at least once and often will follow them through pregnancy looking for intrauterine growth restriction, weight gain, etc. And if they have a pouch or an ostomy, a surgeon may need to be involved as well. You want to make sure their healthcare maintenance is up to date. And then with respect to medications, you want them to stop methotrexate at least 3 months prior to conception. You can continue mesalamine, but if it's sulfasalazine, you want to increase folic acid to 2 milligrams per day. You want them to taper off corticosteroids, and you can continue azathioprine and you can continue biologics throughout pregnancy. I will often check a drug level, and if they have good drug levels at trough and they're on azathioprine purely for immunogenicity, I'll consider stopping the azathioprine and having them on monotherapy. Tofacitinib, a little bit more controversial, and there, if you can avoid it, particularly in the first trimester, I would. What about COVID and pregnancy? So we have seen from the Secure IBD registry, as well as data from New York and Italy, that patients with inflammatory bowel disease do not have increased risk of adverse COVID outcomes compared to the general population, even if they're on biologics. Things that increase risk are steroid use, active disease, and something weird with 5-ASAs. But the pregnant patient with or without IBD does have an increased risk of adverse outcomes from COVID. So they have an increased risk of severe illness, which is ICU, ventilator, and death, and adverse pregnancy outcomes, including preterm birth. If they get COVID during pregnancy, it's been documented that they can send antibodies to the baby to protect the baby. But ideally, you want to vaccinate the pregnant woman, the woman before she gets pregnant. But say she is pregnant, and the guidelines are that they shouldn't delay pregnancy waiting for the vaccine. But if they are pregnant, the general consensus is that they can get COVID vaccine. Now, there's no safety data in pregnant women yet. Those studies are ongoing. But mRNA vaccines do not interact with genetic material DNA because mRNA doesn't enter the nucleus. And it's an inactive vaccine, so you can give it in pregnancy. The American College of the American College of Obstetrics and Gynecology said that COVID-19 vaccines should not be withheld from pregnant individuals who meet criteria, and that they should be offered to women who are breastfeeding. This is the same as the Advisory Committee on Immunization Practices, which is essentially the CDC. And so particularly if they're in a high-risk group, like frontline workers and healthcare workers, they should get vaccinated. But in the United States, every pregnant woman should have the option to vaccinate. WHO came out with a somewhat controversial statement where they advised against vaccinating, except perhaps in high-risk patients, but they changed their wording within 24 hours to align more with CDC and ACOG. So everybody agrees that high risk, so healthcare workers, frontline workers should get vaccinated. In the US, all pregnant women they feel should get vaccinated. One question your OB will ask you is whether your patient can get aspirin. Now, we have always been told in IBD that NSAIDs may trigger flares, but for many patients, taking NSAIDs once in a while is not associated with increased flares. And low-dose aspirin in a study in the New England Journal of Medicine showed reduction in preeclampsia. So if a patient has a high risk factor for eclampsia, which includes immune-mediated disease, they should get low-dose aspirin. And that those are our IBD patients. So often many of our patients are on low-dose aspirin. I have them take it with food, and anecdotally, I've not had significant flares. Okay, so now your patient is pregnant. We monitor them. We see them at least once in the second trimester, and then depending on how active they are, we may see them more frequently. They are being seen by their maternal fetal medicine specialist and being monitored for their growth as well as the embryo's growth. And in terms of medications, it's essentially the same as what we discussed preconception, and we continue biologics throughout pregnancy and lactation. If a patient flares, standard IBD labs can be checked, but understand that CRP and sed rate can be elevated in pregnant patients. Albumin is low, alk phos is low, alk phos is elevated. And so some of the things that we are used to looking at may be altered in pregnancy. We do perform endoscopy as needed. So most patients who flare in pregnancy will have ulcerative colitis, and you can do an unsedated, unprepped flex sig. Young Ko, who's now a young faculty member with us, published this study, and we found that it was not associated with adverse events, and 70 to 80% of the time it led to a change in therapy. So I would not start a biologic in pregnancy unless I was sure what was going on, and so a flex sig helps me there. If they need imaging, and MRI without gadolinium is preferred, but if you're somewhere where they don't have that and it's an emergency, a CT can be done. The amount of radiation exposure from a single CT scan at 50 mg is below the level of concern. And surgery, we have done colectomies in patients with severe UC in pregnancy. The intervention would be for similar reasons as the non-pregnant patient. So if it can't wait, it's better for mother and baby to have the surgery during pregnancy. I will start all IBD medications during pregnancy if indicated. The exception would be thiopurine as a new start in case they get leukopenia or pancreatitis. Methotrexate, of course, is contraindicated, and I do avoid tofacitinib, particularly in the first trimester. Okay. Dami Odufalu, who is our advanced IBD fellow, updated our corticosteroid data. This is an older one, but at that time in piano, we saw an increase in preterm birth, low birth weight, and gestational diabetes, and we did see an increase in clefts in the steroid group. And so we'll see the updated data soon. But steroids are not, you can't say, oh, I'm going to stop their biologic, and if they flare, give them steroids, because those patients have worse outcomes. Thiopurines used to be very controversial, but I think now most people accept that there is no association with birth defects in humans taking the medications at the doses we use them at, and these are often continued throughout pregnancy. So I'm going to go through biologics using piano. Mike mentioned piano. It's a pregnancy and inflammatory bowel disease and neonatal outcomes registry. It started in 2007. So it's in its 14th year. We have over 1,700 patients enrolled, and it was just published in Gastroenterology at the end of last year. And this is through the Crohn's Colitis Foundation Clinical Research Alliance. So the bottom line data is that we had 1,490 women for whom we had pregnancy end data, 379 on no medications of interest, meaning not biologics or azathioprine, 242 on azathioprine, 642 on a biologic, and 227 on combination therapy. So almost 900 on biologics. Of those, 1,431 had a live birth. And based on what drug they were exposed to, there was no increase in birth defects, spontaneous abortion, preterm birth, low birth weight, or infections in the first year. But there was an increase in infections with preterm birth. If you had active disease, there was an increase in spontaneous abortion, and the medications they were on did not impact neural development measured by developmental milestones. So just looking at a breakdown of the data, again, you can see that the combination therapy group had an increase in cesarean sections, but otherwise, overall, there was no increase in adverse events by drug of exposure. The rates of infections at 4 months of life and 1 year of life in the infant were similar based on what drug they were exposed to in utero. And we do know that these biologics cross the placenta. Now, biologics are monoclonal antibodies. So the placenta develops a receptor called the FcRn, which develops around week 14, at least, of gestation. But most of the transfer, 80%, occurs in the 3rd trimester. So the baby can be born with higher levels of drug than the mother. And so we saw that with infliximab, which had the highest level of transfer. On the day of birth, the infant had 2.4 times maternal levels of infliximab at birth. Adalimumab, golimumab, and ustekinumab were similar at 1.3 to 1.5 times infant. The infant had that 1.5 times the maternal level at birth. Certolizumab pegol, of course, is not a full antibody. It's a FAB prime fragment, so there was no active transfer and was not detected in the baby. Natalizumab is IgG4, while all the other antibodies are IgG1. So makes sense that there's limited transfer here. But vedolizumab's IgG1 and still had limited transfer, with the baby having only 50% the levels of the mother. And why that is not clear. It may be it's a newer epitope or something we don't quite understand. But the good news is that it's low levels. And tofacitinib is different because it's a small molecule. It's a pill. It can cross in the first trimester when the baby's organs are forming. And so that's why perhaps there's more of an association with birth defects. Now, one interesting question that's always come up is, okay, the baby is exposed to a biologic in utero and has detectable levels at birth. And we all know that if you take a big break from monoclonal antibody therapy, you may reject it or have a reaction if you get it down the line. So what happens to these babies if they need the drug down the line? We had our first case, which was published in Gastro, of a mother who was on 10 milligrams per kilogram every 4 weeks throughout pregnancy. She had a healthy infant who at the age of 9 developed colitis and eventually required infliximab. They had no detectable concentration before the first dose, which makes sense. But by 12 weeks, they had low levels and were increased to 10 milligrams per kilogram every 5 weeks. And 4 years later, they had adequate levels on monotherapy and were in remission. So in the answer of tolerance versus rejection, at least with this N of 1 study, they tolerate it and still respond to the drug. Ustekinumab is a newer, and data there also support that it's low risk in pregnancy. Same for vedolizumab. Tofacitinib, as I mentioned, is a pill, can cross in the first trimester, and is feticidal and teratogenic in rats at doses higher than what we give to humans. And there's very little human data, but what we have doesn't show significant risk, but again, very limited data. So what about breast milk? Monoclonal antibodies do cross into breast milk, but at a fraction of the amount that you see crossing the placenta. It's at the nanogram level, and all of them cross, but minimally. Breastfeeding while on biologics did not adversely affect infant growth, developmental milestones, and infection rate. So we feel comfortable having mothers breastfeed on biologics. We also showed that infants have adequate response to vaccines, Haemophilus influenza B and tetanus toxoid, regardless of which medication they were exposed to. So being on a biologic or thiopurine did not harm their response to these vaccines. And we do say that if they were exposed to a biologic in utero, they should not get live vaccine for the first 6 months of life. And the only one in the US we give is rotavirus. Despite our recommendation, 43 biologic exposed infants did get rotavirus and they were all just fine. So it's probably overkill, but the recommendation is still not to give it. If they inadvertently get it, the reactions are minor and what's expected with multiple vaccinations. We talked about developmental milestones. We use a validated questionnaire called Ages and Stages and found that there is no that in utero exposure to thiopurines and biologics was not associated with developmental delay, and that these infants did quite well. And actually, compared to the national average, they did better. And part of that has to do with the piano population's likely higher socioeconomic status. But within piano, exposed and unexposed both did well. So to summarize the pregnancy part, preconception planning and education is key. It's very important that your patient knows to come talk to you, ideally before getting pregnant, and that they should be healthy, ideally vaccinated, and in remission. Immunomodulators and biologics allow these refractory patients to achieve remission and conceive, and can be continued through pregnancy and the postpartum. And the children do well with excellent developmental milestones. And remember, no live vaccines for 6 months if on biologics, but all other vaccines can and should be given on schedule. So I'm going to stop here for a second. Mike, are there any questions you want me to answer?
Yeah, thank you. So there are a few questions here. So we'll start with the first one, which is, would you start a thiopurine in a woman trying to conceive in combination with New Start infliximab?
So I would treat the patient. So if she has severe disease, if she's had prior antibody formation to other drugs, I would absolutely treat her with combination therapy. So I wouldn't withhold combination therapy. I'd want to get her into remission. If she's been in longstanding remission with adequate drug levels and has never formed antibodies to a different biologic, then I would consider stopping it. But certainly the key thing is you want to get them into remission.
Okay. The next question is, do these, which drugs pass into breast milk, and are women on these drugs all able to breastfeed normally, or is there a contraindication?
So you should not breastfeed on methotrexate or tofacitinib or ciprofloxacin. But otherwise, the common medications we use in IBD can be used in breastfeeding. So all of the biologics, thiopurines, mesalamine can be used in breastfeeding. Never a reason to pump and dump. You can just breastfeed.
Okay. And then I think with regards to for babies, are they able to get varicella vaccination?
Yes, because varicella is done at 1 year. So at 1 year, they can get varicella. In some regions where there's high measles, they do give MMR at 6 months, and that's okay as well. By 6 months, the levels are either undetectable or trivial. So after 6 months, you can give live vaccines.
Perfect. I think this may be our last one. In regards to live vaccination, are you following regular injection schedules or just starting at 6 months?
I'm following they should all be following regular immunization practices. So they get their Hep B in the hospital at birth, et cetera. So all the inactive vaccines should be on schedule.
Okay, I think that's it. Thank you.
Great. Okay, so we're going to go on to the second section, which is optimizing current therapy. So this is, you're in the clinic, somebody comes in, how do you know what to do? How do you measure? And so this is a slide that looks at what is a target. You've heard a lot about treat to target. So what is a target? In the past, we just used clinical targets, so symptom scores for Crohn's disease and ulcerative colitis. And then we wanted them to be symptom-free and steroid-free. So that was the next hurdle. Then once we had better and better therapies, we wanted biomarker remission. So we wanted a normal CRP and a normal calprotectin. But that still wasn't capturing a lot of these patients, and we went on to endoscopic response. So for Crohn's disease, the CDIS or SES-CD score; for ulcerative colitis, a Mayo endoscopy subscore of 0 or 1. And then most recently with the UNIFY study for ustekinumab in ulcerative colitis, they introduced a new index, which was included histology and endoscopy. So a histoendoscopic mucosal healing, which is endoscopic plus histologic remission. That is a very, very high bar. Many of our patients will never achieve that. And if your patient has clinical steroid-free biologic biomarker remission with excellent endoscopic response, you can optimize what you're on, but you don't have to change therapy to chase histology. But if you can get histologic response, that would be the ultimate goal. And it's been suggested that some patients who have active histologic disease while endoscopically looking normal and have an elevated calprotectin who complain of symptoms will improve with further therapy. So if you have a patient where everything looks good and on biopsies their histology shows active disease and their calpro is high and they're complaining of symptoms, it's reasonable to consider stepping up their therapy. Most of the time, that may be going from 2.4 to 4.8 of mesalamine or optimizing their biologic. I think I would be cautious about completely changing their biologic or adding a biologic in that setting, but everything is patient-based. But just so you know, in the clinical trials, histoendoscopic mucosal healing has become the ultimate endpoint. Therapeutic drug monitoring, this has become very controversial. I think we all agree that reactive therapeutic drug monitoring makes sense. So if somebody is losing response, is symptomatic, you can check a level and see where it should be. And I'm just putting this up for reference. I have to say, I'm not sure we really know exactly what certolizumab or golimumab levels should be. I feel comfortable with the infliximab level. I usually shoot for 5 to 10 there. If they have fistulas, I may shoot for greater than 10, because that came from the ACT trials. From the AGA guidelines, the infliximab and adalimumab levels are here. For vedolizumab at trough, greater than 14 is helpful. Ustekinumab is challenging because many studies suggest that a level greater than 5 in someone who's symptomatic is effective, but the clinical trial data suggested greater than 1.4. And recent data presented at UEGW suggests that maybe levels are not as helpful for ustekinumab. So, use this graph with a grain of salt, but I think where I am most comfortable is with infliximab, adalimumab, and vedolizumab levels. Okay, so what are the AGA guidelines? These recently came out in 2020 and looked at induction of remission in moderate to severe ulcerative colitis. And this is a very important slide because I cannot tell you how many patients we have come to us with severe ulcerative colitis and been given a drug that probably was not appropriate for them. So the AGA recommendation is that if they are biologic naive and they have moderate to severe disease, infliximab is preferred over adalimumab based on efficacy. Vedolizumab is preferred over adalimumab based on the VARSITY trial. Ustekinumab is effective, but was not ranked in the guidelines because it came out for ulcerative colitis after the guidelines were ready. And tofacitinib is effective, but the FDA changed their label and will not use it for TNF naive. So someone comes into your office with moderate to severe UC, never seen a biologic, your choices are infliximab, vedolizumab, and ustekinumab, and you can pick based on their preference, their insurance, their comorbidities, etc. However, if they've had previous infliximab therapy, you would not use adalimumab. Again, adalimumab probably does not have a role in ulcerative colitis, really, based on available data. Infliximab is superior in the naive. If they failed infliximab, unless it was that they developed antibodies and had been doing great, maybe in that setting I would use adalimumab. But in general, prior infliximab, vedolizumab also does not have great data in that setting, but ustekinumab and tofacitinib showed efficacy in the clinical trials, even in people who failed infliximab. So that's where you would go. One thing to remember, patients always ask about de-escalating therapy, and the way I approach it is removing unnecessary therapy. So if your patient is on a biologic, there's absolutely no reason for them to be on a 5-ASA. So if they're on a biologic doing well, you can stop that 5-ASA. Of course, you want to withdraw their steroids. If they're on a concomitant immunomodulator and TNF, would you maintain the combo therapy? I generally use a lot of low-dose methotrexate, 12.5 milligrams once a week with folic acid 1 milligram a day because patients tolerate it better, it's easier for them, it's less side effects. If they're on an anti-TNF, I will generally continue the combo therapy unless they are ready to conceive or they've been in remission for over a year and they have good drug levels and no prior history of antibody. But interestingly, there's no indication to use concomitant immunomodulators with ustekinumab, vedolizumab, or tofacitinib. Especially for tofacitinib, you shouldn't use it. But ustekinumab and vedolizumab, there's been little benefit. So the only time you use combination therapy is with anti-TNFs. So when you look at safety, we have over 20 years of experience with TNFs. We're all very comfortable with them. We understand their injection site, infusion reactions, skin reactions, rare lupus-like syndrome, and they have a boxed warning for serious infections and malignancy. Ustekinumab has very minimal side effects, rare reversible posterior leukoencephalopathy syndrome, very rare, and then a recent JAMA paper suggesting increase in MACE events, that's somewhat controversial, but no boxed warnings. Vedolizumab just works in the gut and minimal side effects, no boxed warnings. So in your older patient, your patient with prior cancer, with serious infections, these two drugs are a great choice. And then tofacitinib has a lot of reported side effects, including box warnings for serious infections, mortality, malignancy, thrombosis, including DVT-PE. But most of those are in the rheumatoid arthritis population. In ulcerative colitis, we don't see as much DVT-PE. The rates are pretty low, and it's a very effective agent. So particularly in a younger patient with severe UC, I do use quite a bit of tofacitinib. So how do you pick which biologic you want to use? So if somebody is, this is essentially how I do it. So severe hospitalized patient or severe fistulizing disease, I'm going to go with infliximab in combination with methotrexate or azathioprine. Moderate to severe UC, moderate to severe UC, TNFs, infliximab essentially, ustekinumab, vedolizumab if they've never been on a TNF before, and tofacitinib. Moderate to severe Crohn's disease, TNF, ustekinumab, vedolizumab. TNF failure, here I'd go with ustekinumab, tofacitinib for UC, or ustekinumab for Crohn's. Safety, vedolizumab has the best safety profile, followed by ustekinumab. And then TNF inhibitors and TOFA have similar safety profiles. Special situations, the older patient. Here, I prefer vedolizumab and ustekinumab if it's appropriate for their disease. If they're in the hospital with severe UC, I'm going to use infliximab. But also remember that ustekinumab falls into the SAD list for Medicare, and so some of our older patients can't afford it. For patients considering conception, I use everything, but do try to avoid tofacitinib. And then if they have comorbidities of VTE, MS, VTE, I try to avoid TOFA, MS, avoid TNFs. If they have spondyloarthropathy, they do better with a TNF or a JAK than vedolizumab or ustekinumab. So I think we have a pause here. So Mike, do you have any other questions for me?
Yes. Okay, so for the first one, we have you altered your induction schedule for steroid refractory ulcerative colitis patients?
So the steroid refractory induction patient, for the most part, that's like the hospitalized patient. I will, if they're hospitalized, I will often give 10 milligrams per kilogram as my first dose, but usually we'll give that second dose at 2 weeks, particularly if I gave 10 mg per kg. If I gave 5, I may give that second induction at 1 week. But aside from that, I have not really adjusted my induction sequence.
Okay, second question, any consideration for using dual therapy, namely methotrexate, with patients who also have some borderline liver disease, or would you go to azathioprine as the immune modulator?
So I think azathioprine also has liver issues, and low dose methotrexate at 12.5 milligrams is pretty well tolerated. So in general, for a patient who has abnormal liver enzymes, who has NASH, who has cirrhosis, et cetera, I do try to stay away from methotrexate and azathioprine, and that's where maybe I would use a biologic that does not need combination therapy.
Okay, and then finally, for someone who develops antibodies to infliximab after azathioprine withdrawal, is it appropriate to reintroduce azathioprine to try to salvage infliximab use?
So that's an interesting question. It depends. So now remember, when you check drug levels, they are all over the place. The drug levels are the same for the most part across all the different tests. So if you get a LabCorp or a Quest or a Prometheus infliximab levels, they're going to be fairly similar. But the antibodies they report really vary. So if you see LabCorp antibodies of 60, it means absolutely nothing, as opposed to a Prometheus antibody level greater than 10 suggests they're neutralizing antibodies. So you have to really look at which lab you ordered it from and how they explain their antibodies. If they have no drug level and high antibody, adding azathioprine or methotrexate is not going to help you. If they have drug level and some antibody, yes, I think adding a immunomodulator there can help.
Okay, I think that's all the questions for now.
Okay, we have one more section. I know I'm speaking very fast and it's late, so hopefully it's not too fast. Okay, so emerging therapies, our last section. So this is just very quickly, whoop, let me move this over, very quickly going over some new drugs you're going to be seeing very soon. So the S1Ps are the sphingosine 1 phosphorylate receptor modulators. And so the one that's commercially available right now is fingolimod, which is non-selective and is FDA approved for multiple sclerosis. Recently, ozanimod, which is a selective S1P1, was approved for multiple sclerosis and is in phase 3 trials for UC and Crohn's disease and look pretty good for UC. So you should see this approved over the next 12 to 18 months. And so this is a oral agent. It does have some side effects, and part of the monitoring program is needing an EKG, eye exam, etc. But it does have efficacy. It does seem to be very well tolerated in ulcerative colitis, and it is an oral agent. So this will be great to have as part of our armamentarium, and we already have some patients on it who we share with our MS colleagues. So MS is increased in people with inflammatory bowel disease. And so if you have someone with MS and IBD and you know you cannot use anti-TNFs, ozanimod is a good choice there. We know about ustekinumab, which is an antibody to the P40 subunit of IL-12 and IL-23, but they're pure IL-23s to the P19 subunit, and gazulcamab and risankizumab are already available commercially for psoriasis and actually work better for psoriasis if you just look at the pure efficacy numbers in the trials than ustekinumab. So being more specific seemed to help. IL-12 on the flip side, though, did not work at all. So it's the IL-23 part that's important. And these 3 IL-23 agents are being studied in ulcerative colitis and Crohn's disease. And we anticipate, again, some of these should be out in the next 12 to 18 months. So you will have these as part of your armamentarium as well. And remember that the doses they use in psoriasis and the doses they use in rheumatoid arthritis for other agents are lower than the doses that we use in inflammatory bowel disease. But gazulcamab and risankizumab are already out there and being used by your dermatology colleagues. And then, of course, JAK inhibitors. Tofacitinib is a non-selective JAK approved for ulcerative colitis. Filgotinib was looked at in Crohn's and UC. Upadacitinib is already FDA approved for rheumatoid arthritis, and it looked good in Crohn's disease and is being studied in UC as well. And there's a topical JAK that's oral that's being looked at. So upadacitinib of these is probably the one you're going to see the soonest. And as I said, it's already out for rheumatoid arthritis, but at a fraction of the dose that you will be using in Crohn's disease. If you have a patient with ankylosing spondylitis, the only 2 agents you can use that cross both ANKSPON and IBD would be upadacitinib, would be a JAK inhibitor or a TNF. Ustekinumab and vedolizumab don't help in that setting. So it'll be good to have some other JAK inhibitors out there. Okay, so with that, any questions on the emerging therapies? And if not, I have some vignettes that I would love to see all your beautiful faces and see what you think.
Yeah, so there are 2 questions. So this actually, one of them is for a prior block. So if a patient has detectable antibodies, say on Prometheus, but adequate drug levels and is in remission, is there a role for adding immunomodulator at that point?
Yes, absolutely. If they have good drug levels, yes.
Okay, great. And then could you please comment on risk immune test use in IBD?
Risk immune, what is risk immune? Is that the Prometheus test?
Actually, I'm trying to look that up myself too, and I'm unable to find it.
Yes, it is. It is.
Yeah, no, is that the one which measures the disease activity, or is it the one that looks at all the, like the ASCA-ANCA,
It helps you to determine which patients are more genetically susceptible to develop antibodies against infliximab or adalimumab.
Okay, so I don't use that, but there was data that showed there's an HLA-DQ05 genetically that if it's present, you are more likely to develop antibodies to an anti-TNF. So there is now a test for that. I think that how that can help you clinically, I'm not sure, except that you would want to put those patients on combination therapy. If you're putting all your TNF patients on combination therapy, at least from the start, it probably won't be that helpful. So I am not using it, but the data for that was not for this particular test, but for that HLA is very interesting that they finally found something that can actually tell you who is at risk. And maybe in that person, you would go to ustekinumab instead or vedolizumab instead. I would say the problem with that is insurance probably doesn't care. And unless you want to write lots of letters and make phone calls, I'm not sure how it'll be clinically useful. Okay, great.
Okay, that's all our questions for now.
Okay, so I'm going to ask everybody, if you don't mind, to turn on your video, if you don't mind, because I'd love to ask some of you or see some of your faces. I'm trying to see. Okay, I see Jin. Who else is here from UCSF? I see Jin and Connie and Dami. Eric, Mal was some time ago, so I won't call on you, Eric. And I know Liat's from Kaiser. And then are the rest of the fellows from Stanford or anyone from Davis? And CPMC, where are you guys from?
Well, I'm at CPMC. I'm Andy, one of the second years.
Okay, and Edward, I see you.
I'm Ronnie, I'm from Stanford.
Hi. Okay, well, you know what? You guys have, I just want you guys to unmute yourself and just talk for this last part, because these are just one-page case vignettes. So this is a 32-year-old man with new onset severe ulcerative colitis who's admitted to the hospital with 10 to 15 bloody bowel movements per day. Hemoglobin's low at 10, albumin's low at 2.5, CRP's high at 50, C. diff and SARS-CoV-2 negative. FlexSig shows Mayo 3 disease from the rectum to the extent of exam, the descending colon. CTE shows pancolitis. So this person's admitted to your hospital. What are your next steps? So what would you do for this patient? What would be your protocol here? Anyone want to be brave enough to unmute yourself and say what you would do? Alexa?
Yeah, this is like a case right up Ronnie's alley. Ronnie is one of our first years. I'm also from Stanford and one of the second years. But this is a patient who, as you've described, has a very severe UC. There's a lot of really concerning features of this presentation, including the endoscopic findings, 10 to 15 bloody bowel movements, low albumin, and low hemoglobin as well. So this is someone who's going to need intensive therapy up front. I think in this case, you would start with steroids, but be pretty ready to jump in and consider infliximab if they're not improving within a couple of days on high-dose IV steroids. This is also a patient that I would let the surgical team know about on the early side, to make sure that that introduction happens before, God forbid, something untoward occurs and we're looking at an emergent situation.
Okay. And then what are some of the things that you go through in your first year protocol? I'll ask Connie, in your first year protocol, what are you going to do for this person? So Alexa mentioned a lot of them, but what else would you do?
I think, making sure we just get a good infectious workup, just ruling out, other stool-borne diseases aside from the C. diff. That's probably the main one I would worry about.
Yeah.
And then in anticipation for starting a biologic, you'll want to check like hepatitis B studies. Don't have time for quantiferon probably, so have the medicine team place a PPD. And then I don't know if I heard Alexa mention early-ish, probably once the C. diff is back, that's negative, I'd probably feel comfortable starting this patient on IV steroids as well.
Great. And then VTE prophylaxis?
Oh, yes, absolutely. Yes.
So everybody, VTE prophylaxis is really, really important. We do that for every single admitted IBD patient. We do that for our admitted pregnant patients too with IBD because they're at increased risk for blood clots. And so, okay, so it's 3, so you start them on IV steroids, they're really not responding, their PPD comes back negative. Can I call on Ronnie? What would you offer them? If I see your face, that means you're okay with me calling on you. So if you don't want to be called on, you can turn your face off. But Ronnie, what would you do? So what would be the therapy you'd offer this person failing IV steroids?
I mean, I think if they're failing IV steroids and like Alexa mentioned, early consideration of infliximab, but also just getting colorectal surgery on board earlier rather than later to not only meet the patient and establish good patient-physician relationship, but also in case they're failing therapy and inevitably they trend that way. Important to get them on board.
So you give them 10 milligrams per kilogram of infliximab, and their CRP is not coming down, it's going up. Their hemoglobin's going down. They're still having 15 bloody bowel movements a day. They met the surgeon, but they threw him out of the room because they didn't want to talk about surgery. So in that set, and they say, what other therapy can you give me? And so now they've been in the hospital, say 10 days, failing, well, say 7 days, failing 7 days of IV steroids and 4 days of 10 mg per kg of infliximab. So just by a show of hands, who would give them a second dose of infliximab early? Who would switch to tofacitinib? Who would switch to ustekinumab? Who would just go back with your attending and talk to them about surgery? So let's say second dose of infliximab 5 days after the first dose. Raise your hands. Okay, switch to tofacitinib. Okay, some takers. And then switch to ustekinumab. Okay, and then go in with your attending and talk about surgery. I think we should do that regardless of what you pick. So Dami, you picked tofacitinib. Dami's our advanced fellow at UCSF. Why tofacitinib? Which is fine. Oh, you're muted, yeah.
Oh, sorry. I picked Tofa just because I think we gave her or him 10 mg per kg of Remicade on day 1, and it sounds like this person's kind of fading pretty fast. And so I think trying another mechanism to see if we can save the colon is important. Just it's been 7 days, and waiting another few days after the second dose of Remicade, I think if that doesn't work, we'd be in a bad place after that. So.
Absolutely. So there's no right answers here. I think this patient is heading to colectomy, but there have been many times we've tried tofacitinib as a Hail Mary, but also set their surgical date. And so we're like, okay, you failed infliximab, we will check a drug level. You failed infliximab, but sending someone to colectomy when they're refusing is assault. So, you really can't do that. And especially for someone with a new diagnosis, they may not be mentally ready. And so in some situations, we have given tofacitinib, usually it's like 3 or 4 days or less. And then by then we go in, talk to them every day. The surgeons talk to them every day and they're ready to go. But so Dami's logic was that there's low albumin. They already failed a monoclonal antibody, try a completely different mechanism. TOFA has not been studied in that setting, but the logic of trying it next is solid. But then the patient has to understand they have a high amount of infliximab on board, steroids, and TOFA. They're at high risk for infection. They're best served with infliximab, but sometimes they just need the extra few days and the thought that they need to feel like they tried everything. So a lot of it is shared patient decision making. I'm very, very upfront about the risks. We have a meet with the surgeon almost on day 1. And so this patient ended up going to surgery but it was probably 3 or 4 days later than what we would have wanted.
One of the questions that's been brought up is, would you try cyclosporin?
So, cyclosporin, so there are certain institutions that still use cyclosporin. Usually cyclosporin is used first before the infliximab. And the reason for that is cyclosporin has a short half-life. And so if they fail cyclosporin and then you try infliximab, fine. But if you give infliximab and then you add cyclosporin to it, there was actually at least 1 death in that clinical series. So that's a lot of immunosuppression. So I can't say TOFA is that much better. But I wouldn't give it afterward. If you were to wanted to try both, you would do cyclosporin first.
Could I ask a quick question?
Yeah.
Oh, it's Amit. I'm from Edmonton. Thanks for the talk. My other question was, and I asked this, yeah, Edmonton.
Great.
And I was one who asked about scheduling. I found that here we're pretty aggressive. Like, so outside the guidelines, but we have a very sick patient, like you guys have mentioned, multiple bowel movements, ongoing decline in hemoglobin and low albumin. We're quite aggressive. Like on day 0, we'll give 10. And then sometimes day 4, we'll do a quick flex. And then it's hard to quantify this with any scoring, but if they're symptomatically a little bit better, but not where we want, if we're, scoring it on day 0 and day 3, we'll just hit them again with another 10 with this whole leaky. And I'll be honest, I'm not the whole leaky gut. Maybe he's just losing a lot of drugs. So we'll hit him like on day 0 and then even day 3 with 10. So it'll be like 10. So we do accelerated supra therapeutic, like you said, like instead of I've seen from my staff that instead of maybe switching agents, and I've seen that too, they try to just exhaust and say like, we've really tried and we're super aggressive. And I'm not saying that that's what should be done. I'm just wanted to get your take on like super therapeutic, super induction.
When you say day 0, it's after the quantiferon or PPD, right?
Yeah, 100%. Yeah. Oh yeah, okay. Sorry, yeah.
So I think there was a study, I think Peter Higgins' group did, where there are multiple studies that have looked at accelerated dosing and have not shown a benefit. So is there a study that they quote to you about giving this accelerated dosing and showing a benefit?
No, that's what I was hoping. And I think
the study
it's anecdotal.
It didn't help.
Yeah, like they didn't show it didn't help, but at that point, I think we're not as comfortable with TOFA. I would say we have maybe 15 IBD docs. I would say very few, maybe 4 to 5 are comfortable with TOFA. So, like you'd mentioned, if the alternative is surgery and the patient doesn't want it, this is what we have left. But I have seen them do it, but we definitely have done that, or like 5-5, where it would be like after everything's done, if you want to say day 1, 5, and then day 3, 5. So it's a splitting the 10 into 2 doses, but giving them more quickly.
Yeah, so if you give 5, I think some people will give that second dose of 5 within a week if they're not responding. But if you give 10, that's it. I don't think you would give another one so soon. Sometimes we'll check a level, and usually the levels are high. They come back quickly enough in that setting, and
that's always challenging.
Yeah. Just increases their risk of infection with no benefit. So the whole theory of fecal loss of infliximab with low albumin, et cetera, you would anticipate a low infliximab level. So if you checked a level and it was low and then you gave a bolus, that's different as opposed to a high level. So we would not do that. The data that, Connie, your cat is so cute. We would, I think the data don't support giving high dose back to back like that. There have been some protocols, I believe, out of Michigan that looked at that and showed no benefit, but we give a big bolus up front. So we give them a ton, and then we will check a level if they're not responding. And, at some point, the longer they wait going to surgery, the higher
the worse it's, perfect. Okay, thanks.
Sure. Mike, any other questions?
Yeah, there are 2 additional questions. So if you're going to surgery for the young patient, would you consider leaving a small amount of rectal mucosa so J pouch can be done in the future?
Oh, no, absolutely. So you would do a subtotal colectomy. The surgeons just want to get in and out. This colon is very fragile, falling apart. So they do a endoleostomy, a subtotal colectomy, and leave the rectum in place. Then they look at the path, and then the patient gets off steroids, improves their nutrition status, and 3 to 6 months later, they go back, create a J pouch and do a loop ileostomy, and then they go back in 3 months and take down that loop ileostomy. So the surgeons do it in 3 stages, which is funny because UCSF was, Ted Schrock's home, and he did 1-stage pouches all the time, and he was great at them. But data from Cleveland Clinic and Mayo Clinic showed an increase in leaks when people were on biologics, et cetera. And surgeons in general, when you have like an eminent person from Cleveland Clinic say everybody does 3 stages and all the surgeons do 3 stages. And their argument is that, a pouch should be a one-time thing. So if you leak from that pouch, you're done. It's better to have those extra 3 months with an ostomy than risk a leak. And it's hard to argue with that.
Okay, and then thank you. So then the next question is, what can you expect in terms of approximate response times for infliximab, vedolizumab, tofa, and Stelara?
So inpatients very different. Inpatient, I would expect people to have some response, see some reduction in CRP, et cetera, within 7 days. But outpatient, for Crohn's disease, so I will say when you look at the clinical trials for ulcerative colitis, usually they do that flex-sig at 12 weeks. When it's Crohn's, 8 to 12 weeks. When it's Crohn's disease, we usually look at 6 months. So to have really significant response takes longer in Crohn's disease. But for all of these agents, if it's your first agent, you're going to respond much quicker than if it's your second or third. Tofacitinib showed response as soon as 3 days. Most of the clinical trials didn't measure at 3 days. They usually measure diaries at 2 weeks, et cetera. But I tell patients for infliximab and vedolizumab, we expect to see response by that 3rd dose, significant response. And some people will respond sooner than that. So by 8 weeks for any UC drug, you should see significant response. 8 to 12 weeks, Crohn's disease, significant response may take up to 6 months, but you would expect the patient to be getting better. So usually we start them 4 weeks later, we have a video visit, how are you doing? But it really is, you don't expect people to really turn around until they've had their induction sequence in it, at least.
Got it. And that's all the questions that we have so far.
Okay. So it's 7 o'clock. I have another case. It's up to you guys. Would you like another case, or are you all done for the day? Anyone want to?
Yes, please.
Okay. All right. So let me move this. So one more case. Okay. So case number 2. So this is a 35-year-old ICU nurse, presents to your office 8 weeks pregnant. She has a history of Crohn's disease in deep remission on infliximab biosimilar therapy. Prior history includes perianal disease and ileocolonic resection. She has several questions for you. And I'm just going to go down the line here. Edward, can she continue her infliximab and or infliximab biosimilar throughout pregnancy?
Yes, I believe she can. Would be preferred.
Okay. Absolutely, throughout pregnancy and lactation. So if she's due for her dose at week, so usually they come see us in the 2nd trimester and we map out their dosing. And if she's due for her dose like a week before delivery, we're not going to give her that dose. We're going to wait. But 4 to 5 weeks before delivery, we feel very comfortable giving that dose. And let's see, Jin, should she switch? Did I ask you already a question?
No.
No? Okay. Should she switch from her biosimilar infliximab to regular infliximab, or can she stay on her biosimilar?
She can stay on it.
Yeah, that's true. I get that question all the time, believe it or not. But infliximab biosimilar is infliximab. And so we would continue that throughout her pregnancy. I would not switch her back. There's no reason to. Eric, do you think she can get her COVID vaccine? Eric, you? Or Eric Mal? Okay. Hi, Eric. I didn't want to call on an attending, but did she get her COVID vaccine?
Yes, she can.
Yeah. So from ACOG, ACIP recommendations, all pregnant women are at increased risk for significant complications of COVID and should get vaccinated, particularly if they're high risk, like a healthcare worker or frontline worker. And then Liat, can she breastfeed on her infliximab biosimilar?
Yes, she can.
Yeah, absolutely. Minimal transfer, no harm. And then Andy, what kind of delivery should she have?
You can have a standard vaginal delivery.
Yeah, because she doesn't have active perianal disease now. The indications for C-section would be active perianal disease at the time of delivery or any kind of rectovaginal fistula, even if she's not active. We would still recommend a cesarean section at that point, but you really need to talk to your patient. So I had a OB from Utah who told me that most of the people there, and also my colleagues in Israel, a lot of them want a lot of children. And you should really only have 2 C-sections, at the most 3. But if your goal is to have 7 or 8 children, then that becomes a problem. And that's something that you need to discuss with your patient. But most patients with inflammatory bowel disease can have successful vaginal delivery. The only time we as gastroenterologists say they should have a C-section, active perianal disease, rectovaginal fistula. A J pouch is shared patient decision-making, can go either way. Most of the surgeons prefer a C-section. Okay, great. Well, it was lovely chatting with you all. Any other questions? I'm happy to answer any.
Great. I think there's one question. So can you comment on pouchitis and your experience on treating it and the different protocols you use to save the pouch?
Yeah, so most patients who have, so pouchitis generally, a course of antibiotics works. So ciprofloxacin is better tolerated than metronidazole. In the pregnant patient, augmentin is a low risk and can be used. There's a variety of antibiotics. If antibiotics don't work and they clearly have pouch inflammation, and you tried combination antibiotics, there has been some data for budesonide, there has been some data for biologics. But sometimes you look in the pouch and it's absolutely normal. And there's a lot of pelvic floor dysfunction causing symptoms in pouchitis. And so if you see a fairly unremarkable pouch and a lot of symptoms, think about pelvic floor dysfunction.
Okay, great. Yeah, I think that's all the questions that we have.
Okay. Well, thank you all. Have a good night. Nice to see all of you. Nice to see you, Eric Mel.
Thank you. Thanks for
Thank you, Mike. Thanks, everyone. Bye.
Thank you.
Thank you.